Okay. So I'm just going to jump right into things here. I don't have any conflicts of interest to declare, and have fairly ambitious plans for the next half hour. I thought I'd talk a little bit about the evolution of addiction medicine, and many of the people in the room here have contributed to that, and I thought I'd talk about some of the recent milestones. I thought I'd talk about some of the issues that have emerged that I think we're all familiar with in terms of safe prescribing. And lastly, I thought I'd just try and quickly run through some of the evidence in terms of different addictive disorders and some of the recent trials that are in some ways quite exciting. So first of all, just going back in time here in terms of the evolution of addiction medicine, this is obviously a paper almost 100 years old now, Ernest Bishop, presumably long deceased, writing, as a definite clinical entity of physical disease, addiction is practically untaught in the school and unappreciated by the average medical man. I'm sorry for the gender bias, but this is sort of what was happening almost 100 years ago, and I think it's worth reflecting to sort of where we are in our history in terms of this huge structural barrier to quality care for people with addiction. Fast forward here to 1948, here's a case report in JAMA. Some surgeons quite excited about something new that they'd stumbled upon as another possible treatment. And then this is actually from the Vancouver province, and not sure how many John Ferry readers there are here, but really showing us that we haven't come that far. This is our provincial medical health officer being taken to task for his support of the methadone program. And it sort of, I think, creates this sense among people that, you know, we don't have an evidence base to really make good decisions in addiction medicine. And the reality is that, you know, that couldn't be farther from the truth. Because of the huge investments in addiction research and the National Institute on Drug Abuse, one of the U.S. National Institutes of Health, by example, invests in addiction research to the tune of about $1.5 billion per year. There's also an alcohol institute. On top of that, you have all the pharmaceutical industry funding, trying to find treatments for addiction. And then, of course, on that, you have all the federal government and other funding outside the United States. So that's what contributes to these papers that you'll see in the Lancet and JAMA and the New England Journal of Medicine, some of which I'll talk a little bit about today, and just building this huge evidence base for which to base our practice around. Outside of these general interest medical journals, there's about 100 peer-reviewed journals now in the area of addiction medicine. And all of this, of course, has contributed to the understanding that addiction is really a disease of the brain, and that these sort of moralistic attitudes that we have held for many years in society, and all the stigma that goes along with that, has really causes more harm than good, and that what is implicated in addiction is really the reward pathway that's in all of us, that rewards us to do the things that will increase the likelihood of our survival and that we pass on our genes to a future generation. So on that hot, sunny day when you haven't had access to water, that glass of water tastes so good because of the reward system that doesn't want you to go into renal failure. When you have a fatty meal that you just can't resist, that cake for dessert, that's the reward pathway rewarding you for high-calorie foods. When we have sex, it's rewarding us because evolution wants us to pass on our genes to future generations. And we can see the impact of external rewards with the new neuroimaging techniques. You can actually see that someone has had a lot of artificial rewards because the brain changes to try and deal with that. And it's no different than other metabolic diseases in medicine. One of the common questions I get is why addiction tends to run in families. And if we know that, you know, alcohol and other addictions tend to run in families, the question is why? Why do we see that? If this is something that causes so much problem for people, technically evolution would say that this is a gene that should go away. And this is a really interesting study that helped unpack this, which essentially was an animal study that looked at the attachment of infant monkeys, macaques, to their parents. And some of these animals, when they get separated from their mothers, they become very distressed, whereas other animals don't. And when they did the genetics on these animals, they found that an addiction susceptibility gene called OPRM1 was much more familiar in the animals who became distressed when they were separated from their mothers. And the hypothesis is that for mammals, this is a good thing in childhood because it prevents young mammals from wandering off into the savannah and getting eaten by a lion or falling off of a cliff. But in adulthood, in the environment that humans have now, where there's a liquor store on most corners, where there's OxyContin and other things floating around in our environments, that system leaves those individuals with those genes at a higher risk of becoming addicted. So there's all this wonderful science, and then this was actually published in the Vancouver Sun, syndicated, I guess, but when I tried to do a screen capture, I could only get the Calgary Herald. But of course, I'm describing this really interesting science, and I'll talk about some of the treatments that are emerging, and yet society has clearly still really fallen behind, and the question is why? So this is a nice report from Columbia University that sort of described this gap between science and practice, which really exists to the detriment of individuals with addiction and, of course, society as a whole. This is what they found when they looked at other chronic diseases in the United States. For common chronic diseases, people get treatment at around 70%, whereas for people with addiction, when you take out particularly providing nicotine replacement to people, about 1 in 10 people with addiction in the U.S. Get addiction treatment. And I guess it's about the same here. So this is why myself and others have been quite focused on the opportunities emerging to have physicians become better trained in addiction medicine. And this is an article from JAMA, co-authored by Nora Volkow from NIDA, really saying this is a clear opportunity for us here. And the emergence of the American Board of Addiction Medicine, I think, is a huge opportunity, and many people in the room here will have done their ABIM certification, and I think it's just a wonderful opportunity for the HIV community, many people here who are already providing addiction treatment to really engage in this, because it's really exploding right now, and I think the interdisciplinary community of HIV care providers is perfectly positioned to pick up some of these tools. And in BC, we're soon going to have an online diploma course in addiction medicine that'll make this much more accessible to people that are already out in practice. So switching gears a little bit to safe prescribing, I think everybody here knows about the problems that have been experienced with prescription opioids, whether they be diverted or prescribed to people, and the huge problems with really iatrogenic addiction and overdose deaths that have resulted from that. This was a study from published in Addiction from Ontario, which really showed just the huge burden of disease in Ontario because of prescription opioid addiction. I am privy to some data from British Columbia. That's not my own work. It's Steve Morgan's group at UBC that hasn't been published yet, that actually shows BC is not in as bad a place as Ontario has been. I think that's partly because we have the Pharmanet in BC, and we can use that as a tool to kind of detect doctor shopping and other things. But it's not all good news here, and this is a paper published by Bohdan Nosik, who's a health economist from our group, that this is, for the most part, a downtown east side population, which essentially showed the increases in availability of prescription opioids over time. So these are street-obtained opioids, so still a problem in BC for sure. This is a study that was everywhere in the news, and I thought for an update I should probably cover it. This was published in JAMA Internal Medicine, and it was looking at the United States and comparing states that had medical marijuana laws on the books statewide in comparison to states that didn't, and showed that there was reduced fatal overdose deaths. And then when they tried to drill down on that and looked at the states with medical marijuana laws, and in time series analyses, they were able to show that as these programs rolled out, there was less fatal overdose deaths. So I could have dedicated my whole talk to medical marijuana, and I know it's controversial, so we can talk about that afterwards. But this was everywhere in the media and on CNN and everything else, so people probably saw it. And I think it's quite compelling as we see the limitations of opioids and chronic non-cancer pain, though of course the medical marijuana thing opens up a whole can of worms as well. I thought I'd talk a little bit about benzodiazepines and trying to compress my commentary on them, because there are meta-analyses that really show that for most reasons that we prescribe benzodiazepines, the evidence base is pretty poor. There isn't good evidence for anxiety and other things like that in terms of producing a meaningful long-term benefit in our patients. And there really is nice meta-analyses that show how they're habit forming, they contribute to falls, motor vehicle accidents, cognitive impairment. The list really goes on. And the cognitive impairment, the meta-analysis would say, persists after you stop benzodiazepines. So I think because patients tend not to fatally, have overdoses and drop dead the way they do with prescription opioid problems, the harms of benzodiazepines have sort of been overlooked a little bit, but this evidence is really emerging quite clearly. Not good evidence that pairing benzodiazepines with psychotherapy sort of helps psychotherapy, and really the best evidence is in the context of alcohol withdrawal. As we get better surveillance databases, I thought I'd just reinforce this point. We're really seeing now, as this paper in JAMA Psychiatry showed, that this is a real culprit medication in terms of people showing up in the emergency room as well. And then I thought I'd talk a little bit about downtown east side data, because we actually really overlooked this for a long time, and then recently, this is unpublished data, we looked at risk factors for mortality in our cohort in the downtown east side, and you can see that the risk of mortality in the adjusted analysis of HIV infection is about a 2.7-fold risk, and if people are getting benzodiazepines on the street and using them, the risk of mortality is greater than 3-fold. So not an insignificant thing in this population. So in terms of recent evidence, I'll talk about sort of a whirlwind tour some of this evidence. The most exciting evidence is actually about prescription opioids and a study called the POTE study. And this is a really neat study where essentially what they did is they took this population of prescription opioid addicted individuals that they're seeing in the United States, which tends to be employed, they tend to be housed, they tend to still have family connections. And essentially what they did is they took a population that had never injected. They've never injected their OxyContin, they've never used heroin, and they thought, okay, what we'll try and do is treat them with Suboxone, which is a medication like methadone that you'll all be familiar with, and we'll try and extinguish their prescription heroin use, and then we'll taper it. A 2-week course, and then a 2-week taper, assuming that, we can help stabilize people. At the same time, they randomized them to an intensive psychosocial intervention, an NIH manualized counseling intervention, trying to get people more mindful of their substance use and give them skills to prevent them relapsing to their substance use. Then they knew not everyone would benefit from this, so they then had those that failed, do a 3-month course of Suboxone, a 1-month taper, and then followed them out 8 weeks after again. And essentially this is what the study showed. People did very well on Suboxone after 2 weeks, but then when you taper it, people start to do poorly, and when you follow them out to 8 weeks, about 6% of people are abstinent from opioids. When you then reinitiate Suboxone on the treatment failure for 3 months, again, people do very well, as you'd expect them to do, but then when you taper this medication over the course of a month, people tend to do poorly again, and about 8% of people are prescription opioid free at the end of the study. So the sort of take-home message from this is that we're really dealing with a chronic disease, and that until we come up with better treatments, people are going to be on this treatment at least for longer periods than 3 months. And I think it's an open question how long you'd want to treat someone for before you start tapering them. There's a couple of new therapies emerging. The first, this is a study from JAMA from 2010 looking at buprenorphine implants. So this is the active medication in Suboxone being given as an implant. And this generated lots of interest back in 2010. It was a molecule created by a company called Titan that didn't get FDA approval. So it was unfortunate in that this would have really provided an advantage in terms of the having to go to the pharmacy every day or the risks around diversion that exist. But the reason that I thought I'd mention it is that the makers of Suboxone, Reckitt Benckiser, have now developed a molecule that is going to be going into clinical trials in sort of the next 6 months. So you'll probably see patients on that over the course of the next year. The other medication that's come out and is available in the United States, it's FDA approved for the treatment of alcohol addiction and opioid addiction, is extended release naltrexone. This is basically an opioid blocking medication. So you actually have to counsel your patients before you give them the medication to not, break your femur in a car accident or something, because morphine and other opioid drugs have absolutely no effect. It's given by intramuscular injection, and it lasts for 30 days. And you may have heard of it because we are doing a trial of it right now at the IDC. So just imagine our current practice of having patients admitted to Vancouver Detox to detox off of their heroin. Their likelihood of relapse is about 90%, and their risk of mortality is increased because their tolerance to heroin has gone down. So this won't be for everybody, but an important tool that's emerging. This is the study that enabled it to get FDA approval in the United States. And it was quite a controversial study because it was done in Russia, where methadone is illegal, so it was compared to placebo. But the benefits are pretty dramatic. That's the secondary endpoint, looking at craving. Hopefully you can appreciate this is not sort of cardiology trials with 20,000 people that after 5 years you see a 3% benefit and people are really excited about it. This has a major impact for patients. This is a study that I think has local relevance. It was done in Switzerland, looking at slow-release oral morphine and comparing that to methadone. Interestingly, this is sort of emerging on the formulary in Canada, and I know that people are incorporating this into their practice already, particularly when patients have chronic pain. But this was an RCT that compared the two and essentially showed greater patient satisfaction, less craving for heroin. I don't think QTC is a big issue, but there was also less prolonged QTC, so certainly relevant in patients with prolonged QTC. Switching gears a little bit to alcohol, this was a study that generated all sorts of enthusiasm for a new treatment for alcohol addiction, comparing gabapentin to placebo, and it really did show, sort of a dose-response effect, and has become a practice amongst a lot of addiction medicine physicians who are excited about it because gabapentin is probably also useful in the withdrawal phase of coming off of alcohol, and then could be used for relapse prevention, whereas the other therapies that are available, acamprosate and naltrexone, generally people have to be through withdrawal. But gabapentin brings issues with it as well, as you all know. And this was a meta-analysis from JAMA from 2014 that looked at the very large number of trials of acamprosate and naltrexone and estimated the number needed to treat for naltrexone is 12 and for acamprosate is 10. I had to look this up last night. The number needed to treat for beta blockers in coronary disease is about 40. So these are safe medications that don't get used, and I think it's just, again, bringing up the skill set of the community of physicians that taking care of patients with alcohol use disorder, because we do have effective pharmacotherapies. For cocaine, it's not as good a story. This is a recent trial, I think, from JAMA Internal Medicine, looking at topiramate, an anticonvulsant, in the context of cocaine. People became very excited about it because of this data, which showed really a compelling effect of topiramate on cocaine use. Unfortunately, 2 randomized trials have since been published showing no benefit of topiramate in comparison to placebo. So I think we'll sort of await the evidence-based medicine people to dredge through that, but at this point it really doesn't look like it's going to be a home run. And then this was in the Vancouver Sun just last week, and I saw it and I thought I'd talk about smoking cessation a little bit, because the smoking cessation tools are really just a total swamp of, signals of adverse events and other things, and certainly this contributed to that. So this headline was about bupropion for smoking cessation and in the context of treatment for depression, and essentially bupropion can be quite toxic according to this report, though if you drill down on it, there were accidental poisonings with people's kids getting into their bupropion and other things. But I think people have seen this and know that bupropion has the potential to cause toxicity. The main issue in the smoking cessation context is that it's not first line. So I'll talk a little bit about some of the other drugs and reiterate that, that I don't have any conflicts of interest. So varenicline, I think, is very safe, and the black box warning alongside that is actually from a very high-profile case report of a famous musician whose name is escaping me, who was totally drunk. Apparently his neighbor was sleeping with his wife, and he was on varenicline and shot and killed his neighbor. And so varenicline got a black box warning. I'll need to look up who that is. Someone can probably do that on their smartphone. Anyway, it raised these concerns that it has all sorts of mental health side effects, and so various trials, including this one, were done. This is with a depressed population, looking to see if it exacerbated mood or other related harms, and basically just showed that it helps people quit smoking more without leading to mood concerns. This is a 2014 paper from JAMA that looked at the question of combination therapy, because if you have a smoker with low mood, can you maybe buttress against this unproven negative effect of varenicline worsening mood by giving them bupropion and then work on the smoking with the varenicline and try and get a twofer there? It essentially showed that it didn't have increased benefits and that there was a higher side effect profile. So again, I think my takeaway message is that bupropion doesn't have the evidence that varenicline does, and I would use varenicline before bupropion. This is the sister study that was then subsequently published that looked at nicotine replacement, which is actually very effective. In my personal experience, when I try and engage smokers in smoking cessation treatment, they've all tried the patch and it didn't work for them, and it's hard to motivate them to try it again. This would be sort of, I think, what my second line would be for someone that failed varenicline, was a combination of nicotine replacement and varenicline together, which beat out varenicline and placebo. So the relevance of this I'll show you in a moment. The other knock on varenicline, if you've followed this literature, because it's a really great evidence-based medicine story, is the potential for cardiotoxicity, which there was a paper in the Canadian Medical Association Journal that actually won the journal's Paper of the Year award, suggesting there was cardiotoxicity with varenicline. If you actually look at the meta-analyses, there's a non-significant effect, and I think given the known cardiotoxicity of smoking, the evidence just does not suggest that this is something that you should be really hesitant to prescribe. Then for our patient population, a couple of really important take-home messages, I think. Not looking at specific medications, there's been a general sense amongst many people, I think, that, we'll have a harm reduction approach around the smoking while we deal with the myriad of other concerns going around, because we don't want to sort of destabilize someone by taking their cigarettes away from them. And actually, this is a nice meta-analysis from the BMJ that showed benefits to mental health when people quit smoking. And I think that's encouraging. This is another meta-analysis that really looks specifically at the substance abusing population, where if you've ever spent any time visiting a substance abuse treatment program or the fourth floor of St. Paul's Hospital, we generally have a harm reduction approach around smoking, and people can smoke like crazy when they're in substance abuse treatment. And it's that same philosophy that if you try and meddle with their smoking, it's just going to make it so much harder for them to get off alcohol or cigarettes or whatever else you're trying to help them with. And essentially what this meta-analysis shows is a 25% increase in long-term abstinence when you provide a smoking cessation intervention. And that's a 25% increase for their alcohol or heroin or anything else. So I think we need to sort of rethink the whole notion that we can have the sort of smoking area at an addiction treatment program, because it's probably doing a disservice for our patients on several fronts, including their medical well-being in terms of the effects of smoking, their mental health, and their addiction treatment outcomes. So just to wind up, addiction medicine, I think, really is continuing to emerge as an area of recognized practice. And again, I just think that the community of addiction care providers is perfectly skilled to really engage in this as additional training and other opportunities emerge. And of course, many of you are already doing this already. Recent evidence demonstrates the need to redouble safer prescribing practices, which again could have been the focus of my entire half hour. Under-prescribing of effective addiction treatments is the other side of the coin, and it's a major implementation science challenge that I think as we start to see guidelines and other things emerging for treatment of addictive disorders, it's going to be really helpful from an implementation science perspective. And lastly, an ever-expanding literature, which I've just scratched the surface of, really does support practice in this area. So I'll just acknowledge the team that I'm involved with. Thank you for your attention. I'd be happy to take any questions.